Shukran. Thank you, Professor Mervet. Thank you for the previous, thanks for the previous presenter. I would approach the presentation differently. I would present like clinical cases, and then I would briefly discuss in broad terms the inherited arrhythmia and cardiomyopathy conditions in pediatrics. I will be on time as well. So inshallah, it will be relatively quick. Okay. So firstly, I will present a case of inherited cardiomyopathy, and then I would discuss briefly cardiomyopathy, and then secondly, I would present a rare inherited arrhythmia or channelopathy case, and then followed by a brief discussion. And then I would summarize my approach for both conditions. Okay, so for case one, so this was a 15 years old girl who was
sorry, Dr. Mohammed, we don't see your screen.
Oh, sorry, you don't see my screen?
No.
I can see it, yeah, دكتورة وفاء. His screen is very well seen.
The screen is of
No, Dr. Zakaria, please stop sharing your screen because I can see his Ebrahim screen. With Dr. Mohammed, Dr. Zakaria. Dr. Zakaria. Okay, yeah. Mohammed Ebrahim's screen is shared. Wafa, your internet could be the problem. Check out and log out and come in and log in again, and then you will see it. Please continue, Dr. Ebrahim.
Okay. So,
Dr. Jamili is seeing your screen very well as well, yeah. Wafa, it is the problem of your internet. Log out and then log in. تفضل دكتور محمد كمل تفضل.
So this is a 15 years old girl who was largely asymptomatic except for fatigue on exercising, but strenuous exercise along with chest tightness and muscle pain. She presented like 2 years ago. She was a product of non-consanguineous marriage with a negative family history, and she was referred to cardiology for further evaluation. Obviously, an ECG was done at the time of the visit with positive findings. So, for example, there was increased voltage on the left leads and left lateral leads, and with the strain pattern. So obviously, hypertrophic cardiomyopathy was suspicious or was a suspect, and as expected, echo and MRI both confirmed hypertrophic cardiomyopathy, along with scar formation on MRI, and it was a non-obstructive hypertrophic cardiomyopathy type. Obviously, typically you want to rule out secondary causes which were ruled out, and hence when you encounter pediatric HCM, obviously there are genetic causes that you want to rule in or rule out as well. But firstly, make sure there's no secondary cause. And Holter was also performed, which only revealed a few PVCs. So genetics testing is the standard of care for patients with unexplained cardiomyopathy. And because I do pediatrics, so I do lots of inherited or genetic, arrhythmia, cardiomyopathy cases. All these patients are referred to me for genetic testing. And so we did genetic testing, which came back positive for LAMP2 mutation that was classified as pathogenic. So LAMP2 is and by the way, both parents were negative. This is a very known reason for hypertrophic cardiomyopathy, and this is in fact our first known case in Kuwait. So what is LAMP2 mutation and what does it do? LAMP2 mutation results in a disease called Danon disease, which is a rare X-linked dominant metabolic disorder. Hence, it is more aggressive in men. The main features are cardiomyopathy, especially hypertrophic cardiomyopathy, but also skeletal muscles might be involved and some intellectual disability as well. Other systems are rarely involved, but the cardiomyopathy, the hypertrophic cardiomyopathy, the muscle is really thick usually with such patients. So as a result, the heart failure symptoms and arrhythmia are the predominant presenting symptoms and the reason usually for morbidity and mortality for such patients. So why LAMP2 would result in hypertrophic cardiomyopathy? So LAMP2, when it's mutated, the function of LAMP2 protein is to help the myocyte get rid of aged cellular contents. And if that protein is mutated, then the aged cellular contents the cell is unable to get rid of them, and hence they accumulate within the myocytes. That results in thickening of the myocytes and malfunctioning of the myocytes. So there's massive accumulation of aged cellular contents in vesicle format, and then subsequently causing muscle disease and muscle thickening. In addition, the cell would be unable to remove aged mitochondria as well, resulting in mitochondrial dysfunction and mitochondrial the symptoms that result from mitochondrial disease. So these are histopathological specimens of patients with Danon disease with prominent vacuoles within the myocytes, and this is the pathognomonic feature of Danon disease. So because it's very rare disease, the largest registry that include Danon patients only included 57 patients. And as we said before, male are more involved or more affected and at a younger age. So for example, age of diagnosis in men is usually less compared to women. Heart failure hospitalization or heart failure symptoms and that require hospitalization presents sooner in men compared to females, and so forth. Heart transplant and mortality. So within that cohort, 25% of patients underwent heart transplantation, and another 25% died from that disease. So it's a very malignant disease, unfortunately, and other systems are less involved, it's less malignant compared to the cardiac phenotype, but there are, like we said, neurological symptoms and so forth, and again, especially in men. Our patient, because she was a female, she had severe hypertrophic cardiomyopathy, but she did not have any extra cardiac manifestation that was obvious on exam or further testing. Just really quick regarding Danon disease, it is you want to recommend lifestyle adjustments. Exercising and starvation might usually enhance disease progression. And obviously, you want to monitor or manage heart failure, the heart failure symptoms. And then, unfortunately, heart transplant is very often needed. And then in terms of arrhythmia surveillance, obviously, they are at risk of significant arrhythmia and sudden cardiac death. So you want to be aggressive with them. And at the very least, you want to, you probably would want to, when you encounter such patients, you would probably want to implant loop or subcutaneous, monitoring, and then obviously BLS training for the family and maybe AED if ICD was not implanted in anyways. And they usually would meet ICD criteria rather quickly because of the severe hypertrophic cardiomyopathy with such patients. And then, but on a positive note, there are gene therapy trials that are ongoing and with promising results. Currently, they are enrolling mainly men, but the results are promising, and maybe one day there is a gene therapy that would reverse the disease or at least stabilize or prevent disease progression for such patients. So, so that's why when you encounter, any cardiomyopathy, you really want to know you want to do genetic testing, because knowing the gene that is causing the cardiomyopathy might inform therapy. And for example, for Danon cardiomyopathy, the patient might be able to be enrolled in gene therapies, and this might be a life-changing therapy for such patients. So this was an example of a patient who presented with a possible cardiac, symptoms. Appropriately, the patient was referred to cardiology for cardiac, examination and rule out cardiac disease. ECG was suggestive of a hypertrophic cardiomyopathy. Family history was negative, so de novo mutation was possible. And then, like we said, imaging confirmed the hypertrophic cardiomyopathy. And then, like we said, if there's no obvious secondary cause, genetic testing is the standard of care. And in this case, it was a pathogenic mutation that in NAM2, resulting in Danon disease. And then thereafter, we screened the parents, and they both were negative. So then there was no need for mass screening. But if one of the parents is positive, then accordingly we would need to test those at-risk family members. So in brief, when cardiomyopathies are defined as muscle disease of the cardiac muscle disease, but resulting in abnormal functionality, but without structural cardiac disease. And then in the absence of any known, in the absence of like coronary artery disease, hypertension, valvular disease, structural heart disease, to explain that myocardial abnormality. So when you encounter muscle disease without any obvious, without any coronary artery disease, valvular disease, and so forth, then you would label that patient as cardiomyopathy, and then you would manage as such. And cardiomyopathies in general are subdivided into LV non-compaction, or arrhythmogenic cardiomyopathies, or dilated cardiomyopathies, or hypertrophic cardiomyopathies, or restrictive cardiomyopathies. Like, like in other words, some patient will have increased LV trabeculations, or some patient will have increased mainly arrhythmia burden, and we label them as arrhythmogenic cardiomyopathies. If there's dilation, then it's labeled as dilated cardiomyopathy. If there is muscle thickening, it is labeled as hypertrophic cardiomyopathy. If there is stiffness, then restrictive cardiomyopathy is how the patient should be classified. And then obviously there are genetic causes and non-genetic causes, and so forth. So that's how you should label each patient with a cardiomyopathy according to what you see on imaging. Cardiomyopathy management requires multidisciplinary care, and you want to often involve a geneticist, heart failure, specialist, electrophysiologist, cardiac imaging personnel. ICU might need to be involved, and psychologists, and so forth. So some multidisciplinary it often requires multidisciplinary team and clinics to take care of such patients. But unfortunately, most of the developing countries would lack such clinics, and the patients are usually not very properly managed. So this was an example of a cardiomyopathy case that I encountered recently, and this is how I approach any cardiomyopathy case. So in terms of channelopathy cases, so that's an example of a case that I also encountered in pediatrics relatively recently. So it was an 11 years old healthy individual who was walking outdoors and then had unprovoked collapse. He was resuscitated in a nearby clinic that was only 5 minutes away. He was found to be pulseless. He was defibrillated twice. and then eventually went to a tertiary or a tertiary, major hospital. Like after 45 minutes of the arrest, he remained unconscious. He was bradypneic. He was bradycardic. He had metabolic acidosis and so forth. So then obviously he was shifted to the ICU. So he had a positive his parents were consanguineous, but there was no family history of note. And he had a normal echocardiogram without structural heart disease with fair cardiac function. And in the ICU, he had two ventricular tachycardia episodes while being on dopamine because of his bradycardia, and he had also frequent polymorphic ventricular couplets or beats, especially when he was under, stress. So this was his initial ECG at presentation. As you can see, his QT is definitely prolonged. So there is definite abnormal repolarization, but remind you, this is post resuscitation. Very often when you have a patient who had a prolonged cardiac arrest, the repolarization might prolong just because of the prolonged resuscitation. So that finding specifically is not very specific. However, you should take note of that. So there's definitely abnormal repolarization for that patient. Otherwise, nothing specific on this ECG. But like we said, while he was in the ICU, he had episodes of wide complex tachycardia that was polymorphic. So like for example in B3, as you can see, the QRSs are differing, and in other leads as well. So he had two episodes of such polymorphic ventricular tachycardia while in the ICU on dobutamine. And in addition, when he was extubated, but for example, wanted to go to the MRI suite, he gets nervous and he throws in polymorphic ventricular beats, different than the VT, and also polymorphic, like we said. For example, here in lead 2, he had bidirectional PVCs. So when it was a puzzling case for us. So we did a cardiac MRI, but remember, he was having so much ectopy when he was awake, so we had to intubate him to perform a good MRI, but it was normal anyways. So now that we know that he has a normal cardiac, no congenital heart disease, he has no cardiac muscle disease, he has normal coronaries, obviously channelopathy or like cardiac channels, disease in the cardiac channels is a suspect. So genetic testing is also standard of care for patients that present with unexplained sudden cardiac arrest. That's what we did. So we did arrhythmia panel through NVT, but came back negative. So now we were puzzled because he was recovering nicely, and we wanted to, obviously, we wanted to discharge the patient. We did not feel comfortable discharging him without an ICD, so we implanted transvenous ICD. However, the etiology is still uncertain. Okay, because of his arrest, or when he collapsed, he fractured his leg, so we could not do stress test at the time of the initial arrest. We gave him Nadolol, and we trained the family for BLS, and we discharged him home to come back for a stress test. Okay, you could argue something we could have done is that to perform medical stress test if he could not do a proper stress test, but that was not done. However, on the vitamin, when he was in the ICU, he was throwing ventricular beats, so he had a medical stress test, but was not done per protocol. Anyways, so the diagnosis was uncertain, but whenever I encounter a patient who arrested and is unexplained or especially arrested when active, stress test is usually something that I try to do. So now you were thinking about the case, given the negative family history, the consanguineous parents, we thought maybe there's something autosomal recessive. We did mom and dad ECGs, both were normal, or he has a de novo mutation of some sort, right? So this was how we were approaching the patient. We noted that the QT intervals were prolonged. And like we said, he had cardiac arrest while active, and he had VT while under betamine. So there is, and PVCs when anxious. So there is CPVT-like phenotype. So there is long QT phenotype and CPVT phenotype. And I understand the previous speaker mentioned, long QT syndrome and CPVT in French, so I was not, able to follow. But I know that he mentioned, in details the long QT syndrome and CPVT disease. So now he came back after his fracture was healed and for a proper stress test. So this is his ECG 4 weeks after discharge. And as you can see, the repolarization is still abnormal and prolonged. So there's still repolarization phenotype and improved, but still abnormal. And then when he was running, he started having bidirectional ectopy, okay, at peak exercise, again, confirming CPVT phenotype. So we did stress tests for both mom and dad and all siblings, and this is his 14 years old older sibling who was asymptomatic. He was also having frequent PVCs and non-sustained ventricular tachycardia on stress test. Mind you, he had a normal Holter, normal echo, and so forth. Okay, so this was, this was a finding that was unexpected for us. Anyways, so just really quick, CPVT is a rare cause of sudden cardiac death in the young. Okay, the hallmark of CPVT is bidirectional or polymorphic ventricular tachycardia. It's a malignant disease, especially if untreated, and 30% of patients who are untreated by age of 40 would die because of the disease. And there is usually it's associated with, or sometimes it's associated with bradycardia and mild developmental delay. Okay, but in order to diagnose CPVT, it's relatively straightforward. So you wanna have a patient who has normal heart and normal ECG, but has emotional or exercise-induced bidirectional polymorphic VT. It should not be monomorphic, it has to be bidirectional polymorphic, okay? Or if there's a pathogenic mutation with genetic testing. And this is a little bit advanced. So with CPVT, it's usually subdivided into typical and atypical CPVT types. Typical CPVT is definitely more common, and but there are very rare gene mutations that results in atypical CPVT. Atypical CPVT meaning the bidirectional ectopy is less common, and there is usually associated repolarization disease. So in my mind, if he's CPVT, he might be one of those atypical CPVTs because of the repolarization disease. But like we said, we did arrhythmia panel, which came back negative. But that arrhythmia panel included RYR2, which is and calsequestrin, which both results in typical CVT, and included trialin and calmodulin, which results in atypical CPVT. But there is one other cause of atypical CPVT that was not included in that arrhythmia panel, which was Tecral. So I was wondering whether this patient has Tecral or trans 2,3-enol CoA reductase-like mutation that might result in atypical CPVT for this patient. In other words, repolarization disease plus CPVT phenotype. So we did whole exome sequencing, and bingo, the results came back with pathogenic mutation in Tecral, which was also, which is, by the way, autosomal recessive disease. So both parents were consanguineous, so both parents were carrier of pathogenic Tecral mutation, but this kid inherited both mutations. So to summarize, this patient had cardiac arrest, unexplained. Family history was suggestive of autosomal recessive disease or de novo mutation. ECG imaging imaging was negative, meaning there was no cardiomyopathy, but ECG was suggestive of maybe atypical CPVT, and genetics confirmed an atypical type of CPVT. Okay, and then we did cascade screening. That brother who with a positive stress test had also positive Tecral mutation, and then the rest of the family members were either negative or carriers for CPVT. Okay, it's a very rare cause of life-threatening arrhythmias. To date, there are like roughly 17 families described in the literature, and the phenotype is usually patients that are young, present young with cardiac arrest, with QTc prolongation and ventricular ectopy, often bidirectional. Okay. But mind you, Tecral might not be tested in commercially available panels. So whenever you do genetic testing, you want to see which specific genes are actually in that panel. And then you want to make sure there's no gene that you want to test for is not in that panel. And then if this was the case, then you have to test specifically for that gene that was excluded in the panel. Otherwise, you'll miss patients. Okay, and then out of the 17 families that have Tecral, a couple of them are in the Middle East. So maybe Tecral is more frequent in the Middle East, especially with the consanguineous, marriages. Okay, and then we published that case because it's, like we said, very rare mutation. So with channelopathies are defined as an inherited arrhythmia disorders without muscle disease. It's a primary electrical disorder. Okay, obviously predisposing patient to sudden cardiac death, and there's no muscle involvement. Okay, so so obviously when we encounter such patients, if they passed, unfortunately we often in our region there's no post-mortem examination, but obviously, so you're left with family history, and you want to test the immediate parents and siblings and so forth. But if the patient survived, then you want to examine that patient, obviously, with ECG at rest, exercise, maybe a high chest lead positioning, ECG, signal average ECG, you want to do MRI, you want to do CT if you're worried about coronary disease or muscle bridging, myocyte cardiac muscle bridging and so forth. And you might want to do drug challenge tests, for example, to rule out Brugada and so forth. Okay, so such patients should be referred to a specific clinic with expertise in all these testing. Okay, and then the most common channelopathies are like either long QT syndrome, is long QT syndrome, of course. But there are less common channelopathies such as CPVT, Brugada, short QT syndrome, and early localization syndrome. Okay, so in general, when you encounter a patient with sudden cardiac arrest or sudden cardiac death, obviously you want to rule out myocarditis, intoxication of some sort, electrolyte disturbances, commotio cordis, like injury to the chest. Okay, and then there are genetic etiologies that result in cardiac conduction disorders, for example, involving sinus node or AV node, resulting in bradyarrhythmias and significant bradyarrhythmias and maybe arrest for the patient, or genetic etiologies that result in muscle disease, or genetic etiologies that result in cardiac channel disease. Okay, or the patient might have a structural heart disease that was unrecognized or undiagnosed, for example, mitral valve disease, coronary artery anomalies, obstructive lesions, and so forth. Or the patient might have WW and present with rapidly conducting AFib, or the patient might have aortopathies with dilation and rupture of a major artery, or there is significant dyslipidemia resulting in premature coronary artery disease, or finally, if everything came back negative, sometimes, unfortunately, we have no diagnosis, and then the patient is labeled as idiopathic VT, VF, and then obviously examining the rest of the family members would be complicated because you're not sure what are you looking for. Okay. Obviously, there are non-cardiac causes as well, so you want to involve other subspecialists to, if there is suspicion for non-cardiac cause of that, arrest for the patient. Okay. So in summary, so good we finished before 10. So in summary, when cardiomyopathies are abnormalities of the heart muscle, okay, and channelopathies are abnormalities of the cardiac electrical system. Often, such patients would require electrophysiology service in terms of arrhythmia surveillance, arrhythmia management, whether ICD is recommended or not recommended, and also for genetic testing and specifically diagnosing the cardiomyopathy or the channelopathy for that patient. And both, whether cardiomyopathies or channelopathies, might lead to cardiac arrest or death. And then obviously, if you are a general pediatrician, for example, please refer such patients to cardiology for further management. And with that, I think I'm done. And I hope the message that I wanted to send is, how to approach such group of diseases in an organized manner, and knowing how to, when is appropriate, or what is the usual workout for such a group of disorders. And I'm happy to answer any questions. And by the way, if anyone wants more details, like I said in my presenting slide, I have a YouTube channel with more detailed cases in inherited arrhythmias and cardiomyopathies. If someone is interested specifically in a specific disease, for example, Teckrell and Danon are both presented in details within that YouTube channel, but there are other cases that are also interesting that you might want to look at. Any questions, Dr. Mirvet?